fact, this morning, almost all the panels talk about social determinants of health. And I'm just so encouraged that this panel actually talked about addressing social determinants of health before people became patients. So I think that is really important. And I heard in our national dialogues around the country under Karen DeSalvo talked about this model of Public Health 3.0. One participant at Flint, Michigan talked about if we only address these issues when people became patients, then essentially you're putting children as canaries in the coal mine. So things have to be addressed at the community level before people became patients. I just wanted to ask specific questions on, local health departments, state and local health departments in the Public Health 3.0 model was called to action to become the chief health strategist for their communities. But at the same time, it's very limited in terms of funding is being cut. Sometimes the first one to go with very limited funding, and also the leadership and workforce issues are very limited. How do you specifically call for federal actions in order to address, how do you strengthen that infrastructure when the funding is being cut, and oftentimes the funding is coming in a categorical fashion? So it is very difficult to, when you build on a Jenga kind of funding infrastructure, depending on this grant addressing AIDS, right, that grant addressing chronic diseases, but being able to blend and braid so you can address more fundamental issues. Mm-hmm. And second of all, achievable in the next administration fashion. So how would the federal government do so that when these chief health strategists are trying to build partnerships at the community level, trying to attract people in transportation, in housing, and all other leaders who don't have health in their title, how do you actually communicate when health is not necessarily in their mission statement?
There's a lot of questions.
There's a lot of questions in there. Yeah, disparate funding.
Let me take that last one first, okay, and just say from a health and all policies perspective, trying to think about what speaks to other sectors, what speaks to my transportation colleagues, to my law enforcement colleagues, to my housing colleagues, to my environment colleagues, and one word we've begun to use is something called livability. We want our communities to be livable. And we want to be able to be healthy and happy in them. And can we coalesce around the idea of what can we do to make our communities look more like the communities that we really want to live and be healthy and thrive and prosper in? Mm-hmm. And then go back to so how do you do that? Well, when the funding is sort of stutter step and very iterative, project by project. And Georges may disagree with me, and my former health commissioner colleagues may disagree with me. I feel fortunate in my state. Our funding has been relatively consistent, and that's not the case in all places. And if your funding's just going flat down, you're in a different place. But I don't think it's all about funding a public health programs per se. I don't think it's a programmatic issue. I think it's a convening, I think, as you said, a leadership issue, and I think it's not just leadership at the federal level or even at the state level. I think it's empowering leadership at the community level, and I think that really starts with bringing people together at the community level. And I think public health is a great convener. Mm-hmm. And I think that's one of the things we do most good. Mm-hmm. For somebody in my role, or somebody at the federal role, encouraging people to do that, and creating, not just encouraging them, but creating the systems where they are going to do that. Mm-hmm. Creating a primary prevention plan for the community, or a community development plan, or a state health plan. Plan the work the plan, get people involved at the local level in doing those things. Lao Tzu observed, 3,000 years ago, that the best leaders, when the best leaders' work is done, the people will say, "We did it ourselves." So we really have to get it at the level where people really see this as their idea. They're going to make their communities livable. Thanks for convening us. We don't need you anymore. We got it.
One of my favorite public health sayings is from Dr. June Osborne, who once said, "When prevention works, absolutely nothing happens and things are very boring, ... Let us all pray for a little boredom."
Yeah.
What that means basically is that our health and well-being is a gift and you cannot take it for granted. And too often in our society, we take our health and well-being for granted until public health doesn't work anymore. So as one who has lived this with all of you, I think when you see where prevention and wellness is not working, you should take that as an opportunity to educate people. This is what public health does for you, because right now, for example, with Zika and with the opioid epidemic, you need investments in public health, and then you need all parts of society working together. We can't succeed addressing the opioid epidemic just working in our health sector. We need colleagues from criminal justice and the police chiefs and those sorts of partners. So when those crises come up, that's a time to educate people how important prevention and population health is, and then hopefully resources can follow.
It's an interesting, your question made me think a little bit, and the answers made me think about how one of the conundrums for me as a patient advocate sort of on the micro, meso, and macro level is that you don't get patients really involved often until they're sick. So then they are in sick care, and so we're not really creating healthy communities and so on. But when I listen to you all talk, and John, you're sort of, and Howard's words about what health is, and when I hear you talk, I think those are words communities could get organized around and could become empowered to get involved, to co-create before there is sickness. Right. Before they have bad experiences in health care, either because health care screws up or because it's just hard to be sick. So I think that's a really hopeful kind of eventuality. Sir.
Dr. Ira Williams, Greenville, South Carolina. I'm tired of talking about the problem, and I think we should start talking about the solution. So I want to share a quote with you that I think speaks precisely to the current status. "You can ignore reality, but you cannot ignore the consequences of ignoring reality." Ayn Rand, not a real name. But the reality is that everywhere we look, the current system, as so many people refer to it as, it's broken. And so my question to each of the panelists is, how would you design a 21st century healthcare delivery system with sufficient authority to provide effective accountability at the doctor-patient interface?
So I can tell you, I would not design a 21st century healthcare delivery system at all. I would design a 21st century health system.
That's right.
Which focused a lot of effort on the front end and emphasized a range of innovation and research that catalyzed our knowledge and shared that as rapidly as we could. I would promote the things. I would certainly look at what kills us prematurely, and we know that's physical inactivity, diet, and tobacco. If we focus on those three things, like a laser, we would help on the health care side for sure, but it also gives you enormous value upstream. And I would spend a lot of time with those people who are in other sectors. By the way, the assumption that they may not know that they're part of our health care or health system, they may not know that, but they are. So the people that pick up our garbage every day, and it's convenience until we have a snowstorm or they go on strike, and then it very quickly becomes a health challenge for us, a public health challenge. And so we need to make sure they understand that the people that build our bridges and infrastructure are engineers, and they do a wonderful job until it's not maintained and it falls down. We have an enormous problem right now right now that's going to cause enormous problems in our country. Flint was the tip of the iceberg on the exposure to lead in our country. Yet we can prevent a lot of activity around lead exposure if we actually decide to pay attention to it. So I would build a health system, not a healthcare delivery system.
And I mean, I would just say ditto. I think that's exactly right. I think that I was just reflecting on something that Howard said about prevention. You know, when we do a perfect job in public health, nothing happens. And it's hard to measure nothing. But I think there's another side to that, and that is that we have to recognize that there's not a constituency, not a big constituency for the vital directions that we're talking about, particularly when we're talking about redesigning our system so that it's focused on health and not just healthcare. Healthcare has to be a part of that, and many of us wouldn't be in the room if it weren't for healthcare at certain critical points of our lives. So I'm not discounting that at all, but we would want to design the system so that that what we all really want, which is health, and if you're not sure about that, just ask yourself: do I want to spend any time in an emergency room today, or in the donut hole of an MRI scanner? Or would I rather be, anywhere else but in a dental chair, even though we have a significant challenge with oral health in our country. So we want it to be there when we want it, but what we really want is health. We've got to create a constituency that says, we have to think about upstream from day one, sometimes before day one. We've got to fund the systems, and I think that's not just funding government. I think that's nonprofit. I think that's thinking of ways to create incentives for ourselves to stay healthy, because we're wired evolutionarily to discount downside risk. It's a dangerous world out there, and if you're afraid of getting eaten, you're not going to go hunt and gather. So you discount that downside risk, right? That's how we are where we are, and it's only when we really can internalize this general cultural change towards a culture of health, where we recognize what we're really trying to get, and then we move ourselves deliberately in that direction, can we kind of counter our fundamental drives. And I think that's how we have to design a health system, where we're very intentional about the things that we're trying to nudge ourselves towards. If we're really intentional about trying to drink more water every day, but our landscape is littered with choices that aren't that, we're all human, and that reward center is going to go, ooh, sweet tea, I like that, I'm going to have some, just this one time, but willpower is a finite resource. So if I say no to the cookies out there today, and that was a hard no, by the way, for any of y'all were watching, but maybe later on this evening I'll be like, oh yeah, but ice cream tonight, right? Because I didn't have cookies today. So we've kind of got to be honest with ourselves. This is not easy stuff. If this were easy stuff, 2/3 of us wouldn't be overweight and obese, okay? It's just not, it's really difficult. We've got to be really intentional about designing our culture so that we're getting joy out of our daily lives without having to move to the easy upside of sugar and calories, or if nicotine's your choice, or too much alcohol, or too much of anything. The Greeks got this, a couple thousand years ago when they said, everything in moderation.
Right.
May I respond?
Really briefly, because I think we want to keep moving through questions.
Very briefly. In the 4th grade, I had acute appendicitis, and I had my appendix removed. In 2002, I had open heart surgery, and 6 weeks later, I had a right carotid endarterectomy, had a big clot removed from a right carotid. And your answers seem to be ignoring my medical needs. So what do you tell people who are going to need a doctor in a hospital?
Oh, absolutely. I'm an emergency physician. I absolutely believe in having the best systems in the world, and I believe we have them, and I salivate every time I go into an ER. I miss it every day. But having said that, I would much rather not need the emergency department. I would love to penalize the health system, the healthcare delivery system, every time that we you know, had folks that don't live productive lives, and say that's actually the failure, not the failure of providing services. But now I'm doing public health, so.
Neil.
Neil Halpin from UCLA. I want to argue that we're facing what relative to the other speaker, we're facing a number of what would be considered 3.0 challenges in our health system, meaning that we're facing really different epidemiology and different kinds of challenges that our society is facing that we haven't faced before. We're using our sort of 2.0 chronic disease set of tools that we're trying to face these 3.0 challenges. And we have a bunch of strategies that are from the 1.0 health system, which are all about acute and trauma care and hospitals and clinics and stuff. And so there's an enormous mismatch between the future we're facing, the strategies we're using, the tools that we have. And unless we start to align those in some way, we're not going to move forward. And I would also argue that the equity, efficiency, and effectiveness problems are all linked to one sort of major 3.0 change. And that has to do with the science that's taken place over the last 30 years. And the scientific revolution that's taken place over the last 30 years is not about the social determinants of health, because as Molly knows and I know, when I trained with Phil Lee and others 40 years ago, we knew about the social determinants of health. This isn't new knowledge. It's just finally, because Mike and others have finally elevated it, that now it's sort of more common knowledge and we're ready to take advantage of it. But what the scientific revolution that's taken place over the last 20 or 30 years is how much we understand, how much sort of biological programming takes place early in the lifespan, how much of what goes on in terms of our lifelong health is determined early in our lives. And the equity issues that we're seeing, as was shown by Peter Orszag early today, where we have these enormous equity differences, those equity differences start in childhood. By age 5, we see the same equity differences in the school readiness and the other kinds of problems. And so when we talk about moving upstream, to talk about moving upstream and only talk about social determinants, that's also 2.0 thinking back to a biopsychosocial model and not really understanding that the way we should be thinking about this is that upstream means not only the social and behavioral issues, but means upstream in the lifespan, moving earlier and getting things at an earlier time frame. Because we're never going to get equity at the end of life with our mortality rates if we start unequitable, because the inequity early on just gets compounded over time. And
but why doesn't social determinants of health, addressing that, which you call a 2.0 solution, why doesn't that involve starting earlier in the life course? Because
it didn't really understand the developmental issues that were going on. It was just, basically just taking the social issue.
But the quality of housing stock, the quality of food availability.
Absolutely important.
And those all affect 2-year-olds, right?
Right.
0 to 2-year-olds.
Where it's having its biggest impact are on the children that we're seeing that are developing with these problems.
Right.
And what we, currently in the healthcare system, of the $3 to $4 trillion that we're spending, we spend less than 10% on kids. And again, from the efficiency issue, we want to move towards value. And when we know where the biggest value of the investment is, and we're spending such a small percentage of it, where we know we could have the biggest impact. And that's because of our accounting and scoring and various other things.
I don't think we're disagreeing with you. I think we all agree with you. I think income inequality and when we talk about going upstream, I think that's what we're saying.
I think Dr. Halfin's point, though, is a very good one. I'm glad he made it explicit, because there are some leaders, I'm going to look to Mike McGinnis again, who his group wrote in VitalDirections about making public health work throughout the life course. So I think that's what Neil's point is here. And we know much more about adverse childhood exposures now and what it does to people's lives, starting at a very young age. So having the population health conversation start literally from the time somebody is born, or before. Before, with good support of pregnant moms, making sure that she's insured and has good nutritional support, those sorts of things. That's the way we got to build a better health system for the future.
There's also, I think, a political challenge that's very real, because as society ages, and this was all stressed in the section writing about aging, and the need to address that grows just proportionately because there's more older people. And if we don't pay attention to what you're talking about, Neil, I think we really will miss the boat, because we are, in a sense, still downstream picking people out of the water, even if we're doing better housing and better nutrition at every stage equally. I think it's going to be a political conundrum how to wrestle with that, because it's never been easy to get the attention and the programs that we need for as much as we need for children.
And this is the first time in human history that we've had more old people than young people. And that's unprecedented. And we've spent a whole century basically developing all that we needed for old age, meaning we went from 45 years to 80 years life expectancy, and the cultural revolution that took place in our country was supporting how people grew older. So Social Security, Medicare, insurance products, mortgages, send all the money to the end of the lifespan. And what we've done now is shortchange the beginning of the lifespan, and we underinvest in this country compared to all other countries. So when we see this mental health epidemic, which is like the new obesity that's coming out, and we have 20 to 25% of adolescents that have mental health problems with impairments right now from Kessler at Harvard that's showing the changing epidemiology. We're ignoring that at our peril. And that's new epidemiology that isn't about smoking and these other issues. What it's about is an enormous mismatch between the rapidly changing society, growing inequality, and how we're raising our kids. And this is just an enormous bolus of morbidity that's in the pipeline of our health system right now, and we're paying no attention to it, just like we paid no attention to the warnings of obesity also. So if we're really going to move forward and start thinking in a forward way, I would say to the president that we do need to have a moon launch or some kind of aggressive program, that we should be thinking about states and actually cities, because cities is where you can move things faster and change it. And that we should really think about really focusing on children, because you already have all those forces coming together, and you could make an investment in children, start shifting some of the monies, Molly, that you've sort of said, and start making a real change in cities around the country. And you could do that fast and make that move in one administration.
That's a really good, solid suggestion. Really good, solid suggestion. Thank you.
Vicki Mays, University of California, Los Angeles. I'm going to not repeat some of the things that Neil said, but I'm going to actually add to them, and we were totally separate on this. First, I want to thank the panelists for talking about well-being, because a lot of times it gets short shrift, and I have to thank the organizers for making sure that I was here. Now, Howard knows this very well. Like, for example, the concept of well-being got put into Healthy People 2020. And what has happened to it is that, there's a lot of, I think, low-hanging fruit that's here that potentially can make a difference. So we have the concept of well-being, we talk about it, we conceptually understand it, but what we aren't doing is we don't have good data about well-being. So for example, I sit on, as my colleague over here does, on the National Committee on Violent Health Statistics, we're advisory to the Secretary about health data. If you look at our surveillance data, we don't have ongoing surveillance data about well-being. We don't have a lot of good ongoing surveillance about mental health. My colleague Neil just talked about some of the Ron Kessler data. Well, what happens is the National Institute of Mental Health is designed only to look at pathology. You could not take a proposal to them about well-being, because it really is in their charter and their mission is pathology. And even then, we don't get to have an ongoing mental health surveillance. And we don't have these ongoing studies. So it used to be every 10 years, NIMH would do one of the big studies. The National Survey of American Life, the National Survey of Asians and Latinos. And so and of course, Ron Kessler does the National Comorbidity Study. We haven't had those in many, many years. So part of even the information that you're getting about mental health and mental health disorders is not in the context that it needs to be. We're not looking at it going up and down. I think we have more discussion about it. I don't know that people didn't have the same mental health disorders as much as what happens is that we have now linked it as we get more concerned about integrated care. We have a little bit more on the physical side, the look at mental health. But it's one of the places that we can direct is the federal government is to collect more surveillance data about that. The problem is we need an office. So, you know, just like you were starting to have this dream team of what would be in the president's office, I think, Howard, you were talking about that. We're a country that doesn't have an office of well-being. There are other countries that do. The Australians do. The Canadians have social inclusion. It's time that we think about, either at the level of the White House or in HHS somewhere, that there is an office that focuses on the well-being of Americans. And that really isn't necessarily about the mental health, but it really is about well-being, because it's well-being that's getting connected to all these areas. It's well-being that you start, you know, getting civic engagement around. It's well-being that really connects people together. And you start talking about concepts such as social connectedness. You start talking about civic engagement. So I think that there is some, as I would say, low-hanging fruit of being able to make recommendations that would direct NIH, AHRQ, and others for what we want them to do. I think it's time to think about CDC, you know, actually in its surveillance data, collecting data on well-being and mental health. And then finally, I think that the kind of third piece would be, can you envision that we could successfully lobby for, advocate, or in some kind of way, raise this profile of well-being and mental health to be within an HHS office with the sole focus of addressing that.
Another cross-cutting theme, it seems to me, is, and it's come out here and it came out in other panels, is the naming of things. That if we don't name something, well, is the language we use as a broad question, and I have more thoughts about that, but I won't share them now. But the naming of things, if what my grandmother used to say, you start off as you mean to go on. If what we want is well-being, then we need an office of well-being. If what we want is health, then we need to sort of name and arrange our funding streams and our organization, you know, our cabinet offices and all kinds of things around health and well-being, and not around health care and disease management. So it's really helpful, I think.
If I could make a point to combine those two thoughts, and I'm sure I'm not
really
the first
quickly, because I think we want to make sure we hear from everybody.
To have a child health and well-being secretary. Many states have children's cabinets, and the idea of focusing on that non-voting constituency, really important.
And well-being, that'd be
Child health and well-being.
That's something I'd apply for a job in.
Hi, I'm Dr. Peter Bickmeneman. I'm the health economist for the American Nurses Association. I am a PhD economist, not a clinician. And one of my forebears, if I can claim him, was John Maynard Keynes, who said, in the long run, we're all dead.
In the long run, we're all dead?
We're all dead.
Yes.
Death is something that, among the 19 papers, at least the ones I looked at, is sort of finessed, if not ignored entirely. In the John Rowe paper, first author, they talk about changes due to the baby boom and the increase in longevity. And the challenge is that it's not just the baby boom, if you will. Starting in 47, there was a dramatic change in age distribution of the population that started then. The Concord Coalition back in 1998 was talking about the future, and they said people often think of, you know, the baby boom as the pig that was swallowed by the python, and they said the problem is the python didn't swallow a pig; it swallowed a telephone pole. The number of people born in the United States before the war was fewer than 3 million. After the war, it was 4 million. It's remained at 4 million just about ever since then. And the baby boom is just the start of this. What's going to happen, what is happening, I used to be the chief of physician reimbursement research for HCFA back in the 80s, And at the time, 1 million or 2 million people aged into Medicare every year. We are already at 3 million people aging into Medicare this year. It will go to 4 and then 5 million before the end of the century. The millenniums are going to be 10% bigger than the boomers, and the post-millennium generation will be 20% bigger than the boomers. It doesn't end when the last boomer dies. It just keeps continuing. And what will happen, and I think what is the missing part, is the leading edge of the boomers will hit 80 years of age in 2030. And Madam President, your successor, if you are in 2 terms and your successor is in 2 terms, will face a different kind of problem because the number of people dying in the country is going to dramatically increase. Right now, well, actually for the last 20 years or so, it's been 2.4 million people dying in the United States per year. 2015, the CDC said it was 2.5 million. It will continue to increase. I say it will go more than double before the end of the century. The death rates actually are stable or improving, but it's just there are so many more people in the generations that started with the boomers and will continue afterward.
So where's your point about the challenge of this? I mean, I hear that it's a challenge.
It's a challenge in that, for the most part, people talk about people aging into Medicare and having an older population.
Yeah.
But Medicare is not a roach motel.
Yeah.
They will check out. And I say in 2030, there will be an acceleration of deaths because people will be hitting their 80s.
Yeah.
I've followed Medicare statistics for a long time, and I have yet to see a projection that shows the average age of the Medicare population reaching 80 years old. And part of the challenge is that as these additional new populations come in, there's an awful big influx of 65-year-olds. There are going to be lots and lots more centenarians, but there will be lots of deaths. And if the current distribution of places of death continues, as it has for the last 30 or 40 years, about 1/3 of the people die in hospital, 1/3 die at home, and 1/3 die in all other places. If 1/3 continue to die in the hospital, the number of inpatient deaths will go back over 1 million, and it hasn't been that high since 1982. The percentage of Medicare days out of total days in hospitals right now is about 46%. It will continue to increase. So there are going to be a lot of changes that, if you will, not much can be done about. These people will die. They will die at home, in hospitals, in hospices, in other places, but it's going to shift the demands on clinicians, particularly in the direction of end-of-life care. And I think the curricula for clinicians should start to change because that's going to be a much bigger component of healthcare.
Right.
So I don't have a question. It's just this is part of what is in the foreseeable future. And like I say, I haven't seen it in the 19 papers, and I think it's something that could be addressed.
Yeah, it was in one of the papers. I mean, they talked a great deal about restructuring the system, building the workforce, and addressing the issue that exactly what you pointed out. It's in there. There's a paper.
Well, like I say, it's sort of finessed in the aging population paper.
But the need to reform education to address both issues, it seems to me, different sort of population issues, as well as the changing roles of healthcare professionals in the education context, could definitely be stronger in the
And utilizing a variety of providers other than the traditional providers.
Yep. Thank you.
Questions from the webcast. The first would like to dig a little bit deeper into the notion of funding for public health. I know Dr. Dreisner touched on this a little bit, but this person is saying that empowering leadership is not enough. Public health needs real dollars. What are some practical and realistic strategies for funding public health?
Practical and realistic strategies?
Yeah,
for
public
funding
health needs real dollars. There's absolutely no question about that. if you think about it, so after 9/11, right, we threw several $1 billion into building public health preparedness, and those dollars have been rapidly going away. And just as they've gone away, we've had a series of public health activity, including Ebola and Zika now. And one of the challenges I find is that we sit around and have these enormous fiscal debates about, for example, Zika, a $2 billion ask, when $10 million per baby gets you to $2 billion pretty quickly. And the economic investment, when I talked about sustainable investment in public health, that's what I meant. Public health needs a sustainable investment. We have to stop robbing the Public Health and Prevention Fund. And the papers do talk about coming up with some kind of ongoing investment in public health. The National Academy of Medicine, through many of the reports that they've done over the last 2 years, have come up with several models or ways to help fund public health. I don't remember the name of the report, Howard, but it was a series of papers that were done, and one of them specifically looked at ways of enhancing funding for public health. But if you Google it, you can find it. So there are models out there to try to do that, and the Public Health Prevention Fund was one idea to try to enhance funding, but of course it's been rated, and so the funding has not come as we anticipated. John?
Yeah, I would just say certainly public health needs real dollars to do what it does, but what we're talking about here is building healthier communities. And public health folks aren't metropolitan planners. They're not county executives. They're not county commissioners. What we really need to do is create the infrastructure or leverage the existing infrastructure to really put the culture of health forward, and to be using the resources that we already have available to us in different ways. I'm not sure that means having to take away existing resources from healthcare per se. If we could just level that out and pull some of the increase out and start focusing on kids. If I had a magic wand and I could create a physical activity program for every child in America beginning at a very early age, that would be the wand that I would wave. And I'm not sure that comes in terms of funding to public health. That may come in terms of funding to education, where our kids are, where they spend 35 hours a week, whether it's in a school or in a structured care center. We can put that time to use to create a love and a joy of physical activity in children, and particularly those kinds of activities that can do their whole lives. So not so much thinking about particular sports, but thinking about things like running and swimming and biking and sports and fitness training, and really being very intentional about starting that at an early age. I don't think that's necessarily funding that goes to public health. But I think that's funding that public health has to advocate for, maybe through the Secretary for Child Health and Well-being. Yeah.
I can extend some of these good comments. Through the Affordable Care Act, there was the Prevention and Public Health Fund that was hoped to reach some $2 billion a year. Everybody here probably knows it's been capped about half that amount in the last number of years. So we do have $1 billion a year for prevention, which is good news. The disappointment is it's nowhere near the $2 billion that people hope for. So that's one pot of money. Again, through the Affordable Care Act, there was initially a lot of monies for community programs, community transformation grants. Unfortunately, those have ended. I think we're in an era where we have to try to integrate these efforts again into alternative payment models and make preventive measures be part of quality for all these new alternative payment models going forward. No one's mentioned today, but I think very important from CMS Innovation Center has to do with accountable health communities where they're trying to tackle social determinants through a community-based effort. So that's a new funding model that's being floated out there and investigated. Even state innovation models that the Innovation Center is putting out, there are a number of states, Oregon comes to mind, where they're trying to put all their Medicaid dollars on the table and use that in better ways and having prevention be part of the outcomes. And then last but not least, there's a provision in the Affordable Care Act about community benefits for hospitals that want to maintain their nonprofit status from a federal point of view. And in order to do that, they have to make a community health assessment and then make some sort of resource commitment to their community. So that's ongoing, and if we follow that closely, hopefully those will lead to some more resources for prevention and population health in the future.
Great.
Okay, just one more question. This returns to the notion Peter Orzag raised earlier about having a health risk score, just like we have a credit score. And so depending on how we define that, of course, it seems like it could be slightly problematic from a social determinants of health perspective to sort of assign a score to people that way. What's your reaction to that concept?
Well, I think that puts the burden on individuals. When we're real clear, it's the social determinants which are not individually based. So, you can certainly get an individual score. If that's helpful, I think it's probably pretty invasive. But I think that we do have measurements. Again, we have a very effective county health ranking system that we ought to finally use and drive political decision making. We have state health rankings that we need to effectively use, again, to drive a range of decision making. They can drive policy making, funding, et cetera. The truth of the matter is we can pretend that when something bad happens that there's this magical private sector out there that's going to save us. But at the end of the day, the last time I checked, most hospitals don't do mosquito spraying, nor do they do disease surveillance in the community, or the range of things that the governmental public health system done. At the same token, in many communities, there are we still need to have effective health care systems, so we have to have both. And that requires us to design the system that we actually want, adequately fund it, and continue to not pretend, stop pretending that these aren't essential services that we need.
I would just add to that, and I was just thinking about what Howard talked about in terms of adverse childhood experiences.
Yes.
And thinking about that as fact, not fate. And I think it's really important for us to, I think about a health risk score, and I would worry that people would think, oh my goodness, since I had this many adverse childhood experiences, or I have this health risk, that I'm fated for X. And the fact is, we're not. It can be difficult or challenging to change stars, but it's not impossible. You mentioned, a child of Korean immigrants, a grandchild of Armenian or Syrian refugees. We are fact, but not fated to the health risks that we have, and I would just be careful about that.
All right. Another question?
Yeah, Kathleen Blake from the American Medical Association, and if it's not been mentioned in the report, and I'll acknowledge I've not read all of the reports, but I think that there is an opportunity that should perhaps be highlighted, and that is for very dense community mapping. And I'm referring particularly to the work that's done by Stacy Lindau at the University of Chicago, who has mapped a very high-risk, high-poverty area south side of Chicago, and is now through a foundation doing the same in New York City. And it is to examine what are all of the health and wellness resources available on literally a block-to-block basis. Because in many of these communities, the lack of infrastructure is related to the lack of information. So what she's been able to identify, for example, is where a drugstore is most needed on the south side of Chicago. because of being able to look at distances traveled. Where are the other drugstores? And then with community activists, be able to specifically reach out to those kinds of companies to say that there is an opportunity, an economic one, granted, but an opportunity for them in a neighborhood that they might not have otherwise considered. So I'd say, open the windows on what you consider the map and what needs to be on the map in terms of access to healthcare related benefits.
Great suggestion in the data and what do we have and what do we need department. One last question, and we're going to end on time.
Okay, this will be an easy toss to you guys. Joy Lewis with Kaiser Permanente, and as I sit here and listen to your comments, all of you on the panel, I actually wonder if you're my KP colleagues. Just looking at the list of the emphasis, talking about the emphasis on prevention, healthy eating, active living activities, the accountability for the health of a panel of patients that a provider may be assigned, the ACEs study that's been mentioned, Dr. Vince Folletti and the CDC, applying our CB dollars to upstream prevention activities, and Dr. Koh, your recitation of the WHO 1948 definition of health, it's almost verbatim to our own total health definition and our strategic priority as an organization around investing in all the ways you've described. And so what I come back to is I don't think I've heard a clear answer to why is it that, and I would argue that Kaiser Permanente is not the only health system out there that's focused on these issues and paying attention and really engaged actively engaged in this work. Why are we not then leveraging the learnings from the existing knowledge and the experience from those of us who are playing in this space and really are leaders in doing, we're showing up, versus viewing us as the anomaly? I get that all the time. Yes, you're Kaiser Permanente, you can do that. Yeah. So if someone could respond to, I know, go ahead, Mom.
Oh, no, I was just going to say, it's a great question for a last question of the
Why do we leave it to Elliot Fisher
day.
to call people together?
I think it's very interesting. I am in California and have spent a long time in various, relationships with Kaiser and all. And I know group health very well, which recently merged with Kaiser, but was an independent and very similar in some ways, not so much structurally, but in its role in the community. And I really go back to what I was saying at the very beginning, is that I think that being a capitated risk-bearing organization is not the complete answer. It doesn't guarantee anything, but it's pretty much necessary that when you get shared resources for a population over time, and it's been painful. Boy, you have to drag some of the medical groups and hospitals kicking and screaming to get to this point, to realize there are better ways to invest the money to achieve the health of the population. And I can tell you, I'm sure you know many stories too, and other people too. I followed and worked on technology with Kaiser very closely for about 15 years. And they did an early study like the VA in the adoption of remote monitoring for cardiac disease. And they found it was enormously successful, and it died within Kaiser because of concerns about displacement of professionals in the care process. 5 or 6 years later, it cycled back again, and now it's very big, and Kaiser's a leader in it. But it's never easy. It's not a guarantee if you set up risk-bearing, but I would argue that the nature of public health is, in theory, having a set of resources to leverage in partnerships, not just directly spending all the money, in order to create health in the population. We talk about health care as though it is all the traditional fee-for-service health care in a sense, just because we're painting with a broad brush. But we're seeing pretty substantial migration of many health systems. And for example, I think it's in Tennessee, Mission Point is I think it's in Tennessee, is a hospital system-based population health program that sells to hospitals, Medicaid, Medicare, in many different places in a couple of states in the South. And they have great outcomes in terms of population health concerns. So it is possible, and I think this is what I meant by, there are many things that Mark and others and the ACO collaboratives have unearthed that are very good patterns, which can be the bedrock for spreading those kind of models. And we're better off if we don't look at it as a pitched battle between public health and the traditional healthcare system, but as something where the migration is partly just the cost pressures are driving us together. So I think Kaiser is a great leader, but hopefully there'll be a lot of others, competing for the ribbons.
I also want to thank Kaiser for being a leader in the so-called class standards, culturally and linguistically appropriate standards that Health and Human Services has been promoting since 2000. And KP has done a wonderful job in our pushing that theme. And I think, again, you've been a leader in that area, so thank you so much.
And with that, I will thank my phenomenal panel and for taking us through toward the end.